Historically, pediatric care has struggled to manage a highly specific presentation, children who exhibit severe, chronic, and explosive irritability. For these patients, the daily experience is a constant accumulation of internal tension. The pressure builds until it fractures the surface in sudden, aggressive outbursts. This graph tracks pediatric mental health diagnoses leading up to 2013. During this period, clinicians increasingly categorized this relentless irritability as pediatric bipolar disorder. However, clinical observers noted that the symptoms of these children rarely aligned with the established characteristics of bipolar disorder. At the time, the diagnostic manual lacked a specific category for children whose primary symptom was persistent, non-episodic anger. Because of this gap, many children were started on mood-stabilizing drug regimens, even though their behaviors did not follow the episodic pattern those medications are specifically designed to manage. The 2013 release of the DSM-5 introduced specific criteria to address this diagnostic problem. The update included a new category, Disruptive Mood Dysregulation Disorder, or DMDD. The addition of DMDD divided the group of children previously labeled as bipolar into two distinct categories based on how their symptoms manifested over time. The category was designed to capture the specific population of children who live in a steady state of severe irritability. This distinguishes them from patients with bipolar disorder, whose symptoms are characterized by cyclical, temporary shifts in mood. By creating this distinction, the DSM-5 established a necessary barrier that prevents clinicians from applying bipolar treatment protocols to children with chronic irritability. When observing a highly irritable child, the practitioner's first task is to determine if the irritability is episodic or chronic. Bipolar disorder typically involves a flat baseline mood that is interrupted by discrete temporary peaks of mania. In DMD, the baseline mood itself is consistently high. The child remains irritable or angry most of the day, nearly every day. In this model, outbursts are not a shift away from the baseline. They are explosive eruptions occurring on top of a constant state of dysregulation. It is easy to mistake a severe temper outburst for a manic episode if the clinician only observes the explosion rather than the days leading up to it. Identifying the true baseline mood between these outbursts is the most critical step in reaching an accurate diagnosis. To differentiate a clinical disorder from typical developmental challenges, the DSM-5 applies strict mathematical thresholds. The first filter requires severe, recurrent outbursts, inappropriate for the child's age. Next, frequency and duration, occurring 3 or more times a week for at least 12 months. Impairment must also be evident in at least 2 settings: home, school, or peers. Finally, these symptoms must have begun before the child reached age 10. A diagnosis of DMDD is only appropriate if the child's symptom profile successfully passes through every one of these filters. Differentiating between these two conditions is what determines which treatment protocol a clinician will follow. The bipolar path relies largely on pharmacological intervention, using mood stabilizers to manage manic episodes. For DMDD, evidence-based care requires psychosocial intervention as the first-line treatment. This includes strategies like parent management training and cognitive behavioral therapy, specifically adapted for emotional dysregulation. When medication is used for DMDD, it is chosen by a clinician to target comorbidities like ADHD or anxiety, rather than a presumed mood disorder. Treating these co-occurring conditions well often leads to a significant secondary reduction in the child's overall irritability. These behaviors are most frequently observed within the K-12 school environment. School counselors often see children who are explosive several times a week and appear irritable for the majority of the school year. In these cases, the primary directive is to seek a thorough differential diagnosis rather than applying a quick behavioral label. Educators must recognize that this presentation is a complex neurodevelopmental issue that requires clinical support rather than standard disciplinary measures. The school's role is identifying the pattern, triggering a referral for a professional evaluation. However, many schools lack the immediate, on-site licensed resources needed for this level of clinical assessment. MentalSpace School acts as an integrated mental health solution for Georgia schools, bridging this gap. The program provides dedicated therapist teams and same-day intakes to immediately assess students with chronic dysregulation. To ensure accessibility, the program is HIPAA and FERPA compliant and accepts a wide range of insurance, including $0 Medicaid. By replacing misdiagnosis with coordinated care, schools see measurable improvements in student anxiety and attendance, stabilizing both the individual child and the classroom.